I'm James Bidwell. I'm a consultant orthopaedic surgeon and I work in Aberdeen.
I'm David Boddie. I'm a consultant orthopaedic surgeon. I work in Aberdeen.
I don't know about you, one of the things which I found when I first started using this was the variety in shape of the implants. We're used to using implants which are all the same, and then you get the tailor-made, custom-fit implants. So different from patient to patient, aren't they? I mean, that's one of the things.
It's a very good point, actually. I noticed that particularly with the femoral component. The last one I did was a posterior stabilised one, and the suprapatellar bit was very different and just fitted his anatomy perfectly.
As an example here, there's a very useful model here, and it does show the differences between this and a normal knee, doesn't it? Because the femoral implant here, you hold it up, and you can actually see that the width of the condyles is very different one side of the other, isn't it? Which is something you just don't see on a normal knee. And the level of cut is very different as well. It's quite asymmetric. And with the polyethylene inserts, they're split into two pieces, which means that, again, it's quite asymmetric, but it matches the shape, size, and thickness required to get the patient's flexion and extension gaps back to normal. So, which is grand, really. I mean, I think it does allow a far more tailored fit and better dynamics and kinematics in the implant than we would be available to us before. So I suppose the difference in process when we're seeing a new patient who's a candidate for a Conformis knee, the patient would need a CT scan, a planning CT scan, and that's sent off to the United States, to the factory in Boston, where they analyze it and basically reconstruct the knee and build a knee replacement around that. And then they're able to provide the kit, which then comes in a delivered box for us. And that, along with a very small tray of instruments, is all that's required at the time of the operation.
And the turnaround time for doing that of 6 weeks is actually quite incredible.
Yeah, considering what it involves, is very, very remarkable.
How would you make the decision in the clinic about who you would suggest as a Conformis over a conventional knee replacement?
I think there's really two main groups of patients. If someone has got complicated anatomy, a deformity, short stature, or very tall patients, or patients who've had previous injuries, having a CT-guided patient-specific implant technique is highly advantageous for starters. I think that group of patients, reasonably few and far between. Your standard patient, I think, patients who are looking for a higher level of function quicker after a knee replacement, I think I always discuss this with them and make my preferences clear to them. Because if I'm very honest, I feel a Conformis knee replacement is the best on offer at the moment.
The technology behind this for me makes so much more sense than some of the other ones that people are doing at the present time, because as you highlighted earlier, the difference in people's anatomy is what wasn't addressed with conventional knee replacement, whereas this totally addresses it.
Absolutely right. Absolutely right.
The patient that we saw earlier, what he said was when he first stood up out of bed, he was very reluctant because he knew how his knees usually felt when he stood up out of bed. But immediately he stood on it, he realised how unstable they felt before his surgery. But he got going very quickly. Physios were very impressed with the speed of his rehabilitation, the return of his range of motion. He's got back to doing a bit of hill walking, not quite, but it's something that he couldn't have contemplated for many years before. He's done really very well after that.
Yeah. Now, I had a patient 2 weeks ago who came in and was 6 weeks post-op, and he had already completed a 5-mile bicycle ride, which I thought was actually going it at 6 weeks.
When I first started doing them, I guess I tended to favour it in the younger patients for the theory that they would maybe do better and last longer. But I think I'm thinking that actually stretching that out, that really it's applicable to everybody.
Yeah.
And not having to put an alignment rod up the inside of the femur would benefit the older population as well for the physiological benefits of that. So I think stretching it out actually, that everybody's suitable for it.
I think the message for our referrers in physiotherapy and our general practice colleagues is that it is a knee replacement which can give people back reliably a high level of function and control their pain well, correct deformity, and I think is a really great option.
Yeah, I've been very impressed with it. I'm very impressed.
Absolutely.